We are live now, doctor.
Thank you, Manchulaji, and thank you everyone for joining in today for our episode 35th of our late night retina sessions. And today we have our masterclass in Vitreo-retinal interface. And our mentor today is none other than Dr. Barbara Parolini. Let me introduce her. She is a distinguished vitreoretinal surgeon from Italy for over 15,000 surgeries and more than 100 peer-reviewed publications to her credit. She has completed her advanced research fellowship at the University of California, San Francisco, and the University of Medicine and Dentistry of New Jersey, focusing on retinal pigment epithelium transplants. Currently, ma'am is serving as the Vice President of the European Vitreoretinal Society and is a board member of the Retina World Congress. Ma'am is globally recognized for her expertise in complex VR surgeries, high myopia, macular traction syndrome. Ma'am is one of the mentors of many academic vitreoretinal surgeries which are available world across. Ma'am holds a patent for her innovation of model for macular buckle, and she will be sharing her insights on the same in today's late night retina sessions. But above all, I would say that ma'am, for despite her remarkable success, ma'am remains one of the most humble and genuinely helpful mentors one could ever meet. So she is actually a true inspiration to all of us. So welcome, Dr. Barbara, for bracing our session. Thank you so much, ma'am.
Thank you so much for the honor and for your kind word. You just made my day.
Thank you, ma'am. I would want to introduce our moderator for today. That is Dr. Sharad Hegde. Dr. Sharad is a senior vitreoretinal consultant at Prasad Netralaya ODP. Dr. Sharad is a alumni of LVPI, and he goes back long. I think we were discussing just before this that she has been from the inception of our late night sessions. So over to you, Dr. Sharad, without wasting any time. Thank you, Dr. Sharad.
Thanks, Avanish, for giving this opportunity. I welcome everyone again to our 35th episode of Late Night Retina. So we hope it will be very interesting and feisty knowledge on the vitreoretinal interface disorders. I once again welcome Dr. Barbara Parolini madam for this taking her out time and joining for this webinar. Today we have 8 interesting cases by our colleagues who are doing the very interesting surgeries in India. And without wasting our time, I think we just go to our first case. Our first case will be presented by Dr. Kalaivani Jaikumar, who is a practicing VR surgeon in the Eye Foundation in Coimbatore. I'll be showing her video presentation right now.
At the outset, I thank Late Night Retina team for providing me this opportunity. Today, I will be discussing a case under the title Taming the Ugly Smiles. A 57-year-old female presented with decreased vision in both the eyes for 5 years. The corrected visual acuity was 680 in both eyes with early cataractous changes. Active length in the right eye was 30 mm, and on OCT, prominent inner and outer macular schisis was noted along with lamellar macular hole. Left eye active length was 29.8 mm with prominent inner and outer macular schisis. Based on the new myopic traction maculopathy staging system published in 2020, we diagnosed our patient as right eye stage 2B plus and left eye stage 2A. The patient underwent vitrectomy in the right eye. After core vitrectomy, triamcinolone was used to stain the posterior vitreous, and PVD induction began nasal to the optic disc with suction only action. After achieving posterior vitreous detachment, vitrectomy was completed. Under a BBG dye was used to stain the ILM. Macular contact lens was used to enhance visualization, and ILM peeling was carried out over the posterior pole with great care not to create any iatrogenic posterior pole retinal breaks. After completion of ILM peeling over the posterior pole, periphery was examined to ensure absence of retinal break. Fluid gas exchange was performed and gas was injected. At 10 days post-operatively, the patient's vision improved to 6/12 with disappearance of inner macular schisis. Similarly, the left eye core vitrectomy was performed. Triamcinolone was used to stain the posterior vitreous. Here, ILM forceps was used to incise the posterior hyaloid initially, followed by PVD induction using suction on the action of the cutter. Again, vitrectomy was completed, and to enhance ILM staining, BBG dye was used under act. Here, PFC bubble was used and macular contact lens was used to assist in enhancing visualization of the ILM peeling. ILM peeling was performed under PFCL bubble. After completion of ILM peeling, periphery was examined to ensure absence of any iatrogenic retinal breaks and fluid exchange was performed. At 6 weeks post-op, the vision improved to 6/6 with reduction of macular schisis. Now coming to the discussion, what is the role of sequential macular buckle in cases with persistent perpendicular traction, and methods to alleviate contrast-related issues, role of PFCL, and when can it be safely used?
Dr. Kalaimani, are you there?
Yes, sir. Good evening, sir.
Yeah. You can give your final remark if anything is there.
Good evening, ma'am.
Good evening.
So this patient had, as I have mentioned, stage 2B in the right eye and stage 2A in the left eye. And we were decided to release the tangential traction, which is causing the symptoms and the macular schisis. And by 2 weeks and 6 week follow-up, only the patient vision has improved. So how would you suggest about going for a sequential macular buckle in the right eye?
Thanks, Kalaimani. So we will take the questions after the discussion, after the masterclass by our master, Dr. Barbara Parolini, where she'll be showing her innovative way of doing the management of the macular traction and maculopathy. Over to you, madam. We are waiting for your talk.
Okay. Well, first of all, I want to thank all of you and also the surgeons that just shown her case. This is the standard of care at the moment, and I would like to propose you a different approach, and we will discuss together whether you agree, and I will try to explain the reasons and the rationale behind my proposal. Okay, so in this talk, I will present you all the data that I have collected in the past 16 years when I started to treat this pathology, and which is actually a big problem, and it's going to be even bigger in time because myopia is expected to grow and double up in 2050 when 50% of the population could be myopic. But in this discussion, we concentrate on high myopia with the staphyloma. So not this type of eyes, but this type of eyes that have an extraordinary elongation, expansion of the eye wall that I deliberately called scleroconus because it's very similar to the keratoconus that involves the cornea. It is a degeneration of the collagen in the eye wall. And the staphyloma, if we study these eyes with a 3D MRI, can happen in the different spots of the eye wall, not just posterior. You see on the left a big eye, and on your right and in between an eye with one located ectasia of the eye wall in a specific point. Staphyloma were classified in 1, 2, 3, 4, and 5. And I can just show you some example of it. Type 1 involving macula and the papilla till the nasal side. A type 2, which is located and focused on the macula only. a type 3, which is located on the papilla. So in this case, the papilla is in the deepest side and the macula is on a slope. And this is very weird. One of the strangest staphyloma I encountered, you see with the arrow pointing to the fovea, which is very difficult also to locate. And the arrowhead is the fovea and the arrows are the edges of the ectasia of the staphyloma. It's been studied that in time, but in many years, and this is very, very important, remember, this eye keeps growing. So these patients were followed for more than 30 years, and you see that the axial length keeps growing 1-2 millimeter every 10 years. 2 millimeters can be up to 6 diopters in refractive error. This is important to know. When you encounter this patient, you have to tell them they will never stop being myopic and more myopic. They will never stop the evolution of the disease. And if this is a wide field of a normal eye, this is the wide field of an eye with high myopia. You immediately recognize it by the thinning in the choroid, but you see the retina is okay. This is a wide field OCT with pathologic myopia, where the expansion of the eye has led to the 3 biomarkers of pathologic myopia, which are atrophy, traction, and neovascularization. All of these, which were summarized in the ATN classification, describe myopic maculopathy. And all of these are due to one factor, the extraordinary elongation of the eye. If the eye elongates, the choroid gets thinner, so it gets to atrophy. The choroid breaks in the lacquer crack, through which the wound healing process leads to the CNV, and the retina undergoes traction. So it is dilated in the schisis first and in the detachment later. So all of these are due to the elongation that never stops in time. It's very, very important to understand this. Let's focus now on the T, on the traction. First of all, if you want to study these eyes, you have to do an OCT. If you just look at the fundus, you see he's myopic, it has the tessellated appearance, but it's only the OCT that tells you that there is traction, even if you don't think about it when you just look at the color or the autofluorescence. What about the pathogenesis? How does myopic traction maculopathy forms? My hypothesis rely on this game of forces on the fovea that are based on the continuous elongation of the eye. So this is an eye, let's say in the 20s, with the thin choroid, but no pathology in the macula. But with the time, the eye can expand and the retina gets stretched into schisis, and then it gets more stretched into schisis and detachment, and then a complete detachment. This is a very typical evolution. I have studied over 15 years natural history through the OCT of my patients, because I asked them to bring me back all their old OCTs. I have hundreds and hundreds of them all in my computers. And so I could collect and reconstruct the natural evolution of MTM. And I understood that we should not speak about types. We should speak about stages, because it is an evolving disease. So that's how I came up with this table that summarizes everything you need to know on MTM, the nomenclature, the evolution in the tangential plane, in the perpendicular plane, the average visual acuity, the time taken to evolve from one stage to the next. And in the next table, I will show you also my proposal for guidelines of treatment. So let's start with the schisis in the inner or inner outer layer, which is a stage 1, that in time evolves into stage 2, where the schisis goes into the outer layer, to stage 3, where there is a mixture of schisis and detachment. In this stage, the patient loses vision because the fovea photoreceptors detaches from the RPE. And then it evolves in stage 4, where, as you can see, the retina is completely detached and the traction inside the retina is released, and there's no more schisis because the traction inside the retina is released. For each of them, 1, 2, 3, and 4, focus your attention on the inner fovea now, which is in stage A, is intact. There is no splitting. But the tangential traction, because these eyes do not only elongate, they expand, they enlarges. From an intact fovea, we can switch to a lamellar macular hole, a splitting in the inner layers, and then to a full thickness macular hole in stage C. So in summary, if we want to define the stage, it is very easy. You look in the macula first and select 1, 2, 3, and 4. And then you look at the inner fovea and select A, B, or C. We can try together. I cannot hear your voices. If you want to participate, I will be happy to. This is a schisis in the inner layers. The fovea is intact. So this is stage 1A. Yeah, let's start with, let's try with you. So what stage is this? The retina is detached, the inner fovea, so stage 1, 2, 3, or 4.
Oh.
So look at the inner fovea, A, B, or C.
It's B.
It's actually, this is no hole. This is the natural fovea. If you look at it, it's the natural
Normal foveal contour.
So this is stage 4A.
4A.
But don't worry, some stages are difficult. But look at this. There is a mixture of schisis and detachment. 1, 2, 3, or 4.
3.
3.
B.
A, B, or C. There is
B.
exactly.
Yeah,
This is stage 3B. Perfect. So this is a schisis and detachment. 1, 2, 3, or 4.
3.
Okay. A, B, or C in the fovea?
B, O.
A. This is
A.
3A because this is the normal contour of the inner fovea. And it's important to tell the patient there are no holes because I will tell you why when we speak about treatment. So this was the publication, which was actually validated by a large group, and you actually just validated yourself because you just told me that you look at the table and you just learn how to stage MTM. It is very important because at this point you will not speak about schisis or detachment. You will speak about the specific stage. It will be more convenient to learn also between us how to treat stage by stage. What about treatment? First of all, sometimes these patients are told to do nothing because everyone is afraid to treat MTM because these are difficult cases. But let's go back to the evolution. If the problem is the progressive elongation of the eye till the retina detaches because it cannot follow the excessive elongation, what does make more sense? To push and elongate the retina from the inside, or to push and shorten the sclera from the outside? If you think about the motivation, the initial cause, you immediately understand what makes more sense. Since it is the elongation, we have to shorten the eye. That's it, as simple as that. In fact, in the history of treatment of MTM, everything started by shortening the eye. 100 years ago, think about that. This colleague Shevelev in Russia started to shorten the eye with inserting fascia lata all around it. And the first macular buckle model was designed in US by Scapens. They were applying very difficult buckle, basically removing the muscle, tilting the eye, and suturing behind the eye. The technique evolved in different ways, and then it was abandoned because vitrectomy arrived, and everybody tried to solve every problem with vitrectomy that allowed to see inside and was actually easier to perform compared to macular buckle. But what does the literature report as an average success in with vitrectomy in MTM? The functional success is reported in 60% and anatomical success in 80%, which is actually true. You can experiment that. This is one of the cases like the one that our colleagues just shown in the video. But the presence of more severe cases is linked to anatomical and functional failure. And I'm sure you all experienced bad results. Why? Because MTM is vitrectomy is linked to a high rate of relapse of macular detachment, high rate of reoperation, high rate of iatrogenic full thickness macular hole, and more use of silicone oil and secondary glaucoma. So the literature basically, like a ping pong, went back from macular buckle to vitrectomy. I presented my first result in 2009 at the Heaton meeting, and then you can see in the literature more and more reports, and some of them are mine because I keep collecting all the data of the patients that I operate. And this is the last one. It went out a few months ago, actually last month. I published a large series of 206 eyes operated with macular buckle, followed for up to 16 years. And I proved that the anatomical result is 100%. If you center the buckle, there's no way that you do not solve schisis and detachment. But why a case like the one reported earlier by our colleague, she treated with vitrectomy and peeling as everybody does, and it might work. If you have a gentle staphyloma, very shallow like this, it might work. But if you have a deep type 2 staphyloma like this, which is actually a scleral detachment more than a retinal detachment, if you do vitrectomy, you risk to break the retina. Even in a case like this, if you push down the retina, and most of all, if you peel anything on top, I can assure you, you will induce a full thickness macular hole and the patient will not have vision. Even in a case like this, there are like two photoreceptors still embracing each other. If you push the retina down, you will break it. In fact, he was operated with vitrectomy, and this is the result. No vision, retina is attached, but no vision. So among the publication, I want to highlight this one where I advise these guidelines written in red for each stage. So basically, I advise to treat the schisis and detachment only with macular buckle. If you want to treat a hole, yes, then you have to do vitrectomy going inside. But first of all, do the buckle, except in stage 1, because the buckle should be proposed where you have the schisis. Actually, in the table, I was suggesting stages 3 and 4. But telling the truth, since 1 year, I have switched to proposing the buckle already in stage 2. Why should we do the surgery and in this way? Vitrectomy for the holes and macular buckle for schisis and detachment. Everybody always at the meeting, they tell me, why do you treat vitrectomy with this difficult surgery? Because MTM spontaneously can improve in many, many eyes. Well, yes, it was published, but then I have observed that the spontaneous improvement should be defined temporary spontaneous improvement, because as I told you at the beginning, these eyes keep growing all their life. And MTM can restart like 5 years later, 10 years later. Look at this patient. He started in the figure A, you see a stage 3. That actually goes to stage 4. And in the C, you see a spontaneous improvement, but then it starts again and it goes back to stage 4. Look at this in the progression, in the figure number D, with the letter D, he developed a detachment. In figure E, he goes back to schisis, but then he goes back to a detachment 1 year later. So when you find a spontaneous improvement, tell yourself that most of the time it is temporary. Look at this patient. I started to collect their OCT from 2007. You go from A to B detachment, to E spontaneous improvement, F and G spontaneous improvement, but 7 years later, the disease starts again. So this is a dynamic disease. If you don't treat the staphyloma, it will come back. And these are the guidelines for treatment. So why macular buckle and not vitrectomy? I want to show you this case. Sorry for the bad OCT, but this is a very old OCT collected from 2010. The patient was treated with vitrectomy and gas, and then she had a relapse, and she was treated with the vitrectomy and silicone oil, and she was fine. She was fine with a good postoperative vision of 0.7. She remained attached for 4 years, even after silicone oil removal. So if we judge this case, we will say vitrectomy works. However, it comes back. So 5 years after silicone oil removal, she has a relapse in MTM. And then she was observed, she had an improvement, and then MTM came back. 2016, 2017, she switched to stage 4C, very bad. So she was reoperated multiple times, believe me, and then she came to me in this stage 7 years after the first vitrectomy. So I did macular buckle and I treated the hole and the disease stopped. So my message to you is, yes, you can solve MTM with vitrectomy if you have a shallow staphyloma, but remember the disease will come back until you treat the staphyloma itself. So in summary, these are the guidelines. Treat the hole from the inside, but treat the schisis and detachment from the outside. The peeling is always very difficult because there's no contrast in these eyes. The intraoperative OCT is very helpful, but it's not so common. Anyway, it can be done with the staining. But definitely you need to learn the macular buckle. So these are all the macular buckle that I modified starting in 2007 and nowadays. And this is what I propose now. Actually, I'm trying to make it smaller and the smallest I can. And this is how it is made today. It has an L shape or a J shape. And this is the macular buckle loading device that is very helpful to ease the surgical strategy. This is how the buckle and the loading device are connected together. There is a lodge here for the light to use a transillumination. And this is in summary the technique. Believe me, it is a 30 minutes procedure under local anesthesia. I also use sedation. I open the temporal conjunctiva and the tenon. I isolate the superior and temporal muscle. You can mark where you want to place the suture, but I will tell you how. Basically, you have to open up the superotemporal quadrant and prepare the macular buckle with the light, which is you can do without, but the light makes it easier. If you use the loading device, it's even easier. You insert the buckle in the superotemporal quadrant very easily, like that. And then you pass the suture through the hole, and then the second hole. But the most important step is to locate the buckle through the flat lens. You see the transillumination and the buckling effect very, very well through the microscope. And the surgery is done. The key of the surgery is centration. This is the same surgery view from the lateral view, so you see even better the insertion. It goes inside very, very easily. And then you suture, passing the suture through the hole. So how to decide where to place the suture? I had done a study trying to correlate the axial length of the eyes. These are a group of eyes that I operated. You see in yellow the axial length, and in red the distance, limbus, needle, where I placed the suture. But these, you don't need to learn this. It was just to tell you that I found a good correlation between axial length and the distance where to place the suture. But in the end, I suggested to the company to make small, medium, and long macular buckle in order to be able to suture always around 12 millimeters from the limbus. So there are custom buckles that can allow you to suture always at the same distance. So I have operated certainly more than 400 buckles since 2002 when I started. And for some of them, I have the whole follow-up. And I can confirm that if you center the buckle, there's no way that you don't treat schisis and detachment. You have 100% anatomical success. The functional success depends on the entity of atrophy in the macula and the anterior media, but most of the patients can gain a lot of vision. These are just some examples, pre-op on top, post-op in the bottom. You see a flat retina, the hole is closed, vision is very good after surgery with no scotoma. Another example, pre-op to post-op, pre-op to post-op, pre-op to post-op. See, this is a patient with this eye destroyed by multiple surgeries and glaucoma. He comes for the other eye. He has a detachment with schisis with this huge traction, but extrafoveal. I'm sure that most of you would be tempted to go to vitrectomy and release the traction. However, it's not in the macula. So I placed the macular buckle. He gained a lot of vision, and still the traction is there, but on the nasal side, so it's insignificant. This is another case. Look, if you look at this wide field OCT, you immediately understand there's no way to treat this eye with vitrectomy. She has also a full thickness macular hole. If you do vitrectomy, you cannot close that hole, I guarantee. Instead, on your right, you see the result after one surgery: macular buckle, vitrectomy, ILM flap, and gas. And this is the result 2 years after surgery. Actually, it's now 4 years. She still has 20/50 vision. This is very interesting because this is a case control. It's the same patient that had a stage 3A in both eyes, similar MTM and similar vision. One eye was treated with macular buckle, the other eye received a vitrectomy and no ILM flap and no ILM peeling. And see that eye treated with the buckle attached and the eye treated with vitrectomy detached with a full thickness macular hole. And then I treated also the other eye with the buckle. This is to show you that the eye with the macular buckle looks very normal, but the eye with prostaglandin looks very bad after vitrectomy and glaucoma. So what about the complication of buckle? Nowadays, the only complications that I still face are some cases with the diplopia and deficit, elevation deficit looking up. and some extrusion through the conjunctiva, which I think are very acceptable complications compared to the initial pathology. The microperimetry and visual fields improve all the time if they have no atrophy. This is how the buccal look at in the 3D MRI. And this is a very important topic. Does the buccal induce choroidal atrophy? The answer is no. So this is a progression of atrophy, which is the natural history of the disease. It was published by Kyoko Ono Matsui over an 18-year follow-up. It's unfortunately these eyes, as I said at the beginning, they keep elongating, and unfortunately the choroid deteriorates, and that's why they develop atrophy. So I asked the two colleagues of mine to observe the evolution of atrophy in a group of my patients, comparing the operated eye versus the non-operated eye. And so they collected 116 eyes of 71 patients, 70 eye operated with macular buckle and 46 eye non-operated, and looked at the operated eye had a very a worse staging of myopic maculopathy preoperatively. However, they discovered that none of the patients presented macular buckle-related atrophy. And these are some examples. Over 10 years, you see top pre-op and the bottom 10 years after surgery, no induced atrophy by the macular buckle. This is another example after 7 years. And this was published as well last year. So I will conclude with my best patient, because some people think that after macular buckle, this patient cannot gain any vision. This is a 54-year-old male, 2200 vision, 32.8 millimeter axial length, and 22 diopters of myopia. He had a stage 3A with an outer lamellar macular hole. And this is the flat retina 3 years after macular buckle. I then removed the cataract and implanted a multifocal IOL, and he can see 20/20 far and near uncorrected. So this is spectacular, but this is to tell you, to give you the hope of a very good functional results if you treat well these patients. Thank you.
Thank you, Dr. Madam, for your wonderful presentation and very beautiful results what you have got from the macular buckle. We here still, unfortunately, we are not getting the macular buckle directly in India right now, and we all are eagerly waiting for that to do cases on the macular buckle.
Yes, yes.
And
actually, the company can deliver. The problem is still, I think it's still too expensive to be
cost is
used
the issue.
easily. But I will start a clinical trial to obtain registration, and probably it will be manufactured in a cheaper way, so it will be more widely used.
That will be
I would
very
like to
great.
answer to the colleague that presented the video before me.
Yeah, yes, ma'am. So, she had asked mainly 2, 3 questions. The first thing was, have you done any roll or sequential buckle? Means if after doing a PPV, you have done a buckle, or after the buckle, you have to go for a PPV. What is your experience on that, ma'am?
Okay, so I have a series of eyes that had been already operated with vitrectomy, and for some reason they were non-successful because maybe the MTM remained or relapsed. The macular buckle can be applied even after vitrectomy, and so it can be done. I think it's a good idea because, as I shown, I have a series of cases that shown relapse of MTM like 10 years after surgery, 5 years after surgery. So to treat the staphyloma guarantees to the patient to stop the disease forever. Of course, my suggestion when you will be able to will be to start with the buckle, because most of the time you don't need to go inside and remove the vitreous or and removing the ILM. I think it's not good for these eyes because sometimes you induce a full thickness macular hole. And even when you don't, if you look at the patient OCT years after surgery, you see a progressive thinning of the retina, and vision drops. If you do microperimetry or visual field, the sensitivity is not good. So it's better not to touch these retinas.
Yeah, few doubts on the macular buccal surgeries. As we know, all the high myopic people have a very less scleral rigidity. Rigidity will be very less. So, what are the chances of any perforation? Have you had any complication of scleral perforation or anything like that?
Okay. So no perforation, but it is true that some of them have a very thin cornea, a very thin sclera, sorry. And usually we can see that because when we open the quadrant and remove the tenant, we can see the blue stripes. So when I see that, initially I stopped the surgery and closed the case, but then I started to reinforce the sclera by applying a layer of tuto patch, porcine pericardium. So basically, I apply a very large patch that I suture, maybe to avoid the sclera, I suture at the insertion of the muscle. So you have another layer, and then you can apply the buckle on top. I actually have some video that I can show later.
That will be great. That's nice, ma'am. And about you are telling about the buccal centration part of it, where we need to see under the contact lens to
Yes.
see whether it's centered or not. By chance, the next day when we see it is decentered, is it possible to take it
To recenter.
immediately and you can recenter it, ma'am?
What I do, my tip to avoid decentrations are look very well through the flat lens, and have with you a picture of a color picture or black and white, but better color of the preoperative fundus, and mark where the fovea is, because sometimes it's very difficult to know where the fovea is in these eyes. And keep it by the microscope and search for point of reference, okay? Because then you know where the fovea sometimes is very inferior, even 4 millimeter more inferior than the optic nerve. So you need to know preoperatively, okay? And if you use transillumination through the buccal, will be very, very helpful. If you have decentration, remember that a mild decentration is acceptable, no need to redo. You need to have the fovea here, here, or here. Okay, so if one part of the buccal touches the fovea, don't redo. It will work anyway. But if the buccal is totally discenter, then you have to take immediately to surgery. Don't wait, and adjust the suture in order to center. Because if you wait, then you will have a fibrotic tissue all around and you will not be able to redo the surgery. So within 1 week, redo.
Can I use IOCT for the centration, ma'am? Any?
I use intraoperative OCT all the time, and it's very, very, very useful. But I didn't want to focus on that because it is not widely used. But if you have it, it's spectacular.
Nice. So now coming to the vitrectomy in the macular traction maculopathy, which you are talking about, yes, it has a bit of complications. But beginners for the MTM surgeries. So what step you will tell it's crucial and what can be done for the visualization of the ERM part of it, or the role of any PFCL you use while peeling the membrane?
I'm sorry, I want to make sure I understood. Is it still in MTM, you mean?
Still in MTM, any PFCL you use to peel the ILM?
PFCL.
Yeah.
Okay. So let's say that we want to peel the ILM because we have a macular hole, right? This is the only case where I suggest to peel. If you have a hole, no hole, no peel, okay? So let's say we have a hole. What I do, I stain with I use a blue staining. It doesn't really matter. By the way, I want to tell you that I'm conducting a study on toxicity, and I found out that the action of light is worse than chemical. So most of the toxicity we see comes from the light. In fact, so the staining can be very useful to speed up the peeling because the timing is very important. So if you have a detachment, then PFCL can be useful to flatten the retina and hold down the retina and peel. If you don't have a detachment, I suggest to avoid PFCL because if you make any hole and you don't want any problem with PFCL, an unwanted problem. So I think that the only indication is detachment. So you should flatten the retina first through a fluid exchange, inject a bubble of PFCL to cover the whole posterior pole after staining, and then you make the flap, and then you aspirate the PFCL remaining with the flute needle on top of the papilla.
That's a
Okay.
very nice this thing. So I think in India, many of the institutes are waiting for you to.
Telling the truth, sorry, I want to finish that. If you have, of course, when one day you will do macular buckle, you will always have a macular buckle first, and then you will do the peeling. And if you have that, there's no need for PFCL because your retina will be flattened by the buckle first.
So I think most of us and institutes we are waiting for your clinical trials to come, and we'll also start doing the macular buckle. So we move forward from the macular traction maculopathy to our next set of cases. So the second case will be presented by. So the second case will be presented by Dr. Virangi Doshi. She is doing her fellowship in Vitreo-retinal and ocular oncology in Shankaraya Hospital, Bangalore. She is showing us a very interesting case here.
Good evening, everyone. I'm Dr. Virangi Doshi, and in today's session of Late Night Retina, I shall be taking you through a case of a 20-year-old young man who came with complaints of gradual decrease in vision in his right eye since about 6 months. He was a known case of retinitis pigmentosa and had undergone vitreo-retinal surgery for macular hole in his left eye in 2018. On presentation, his vision was 6 by 60 N36 in the right eye and 6 by 9 parts N8 in the left eye. OCT of the right eye showed a lamellar macular hole along with an associated epiretinal proliferation, sciatic retina at the posterior pole, and significant outer layer loss. Considering his gradual decrease in vision, we decided to plan for a surgery. 3 standard 23 gauge ports were placed and anterior vitrectomy was done. PVD was induced with cutter. And further, tricot was injected to identify the extent of vitreous detachment and to assist in removal of the remnant cortical vitreous. Remnant particles of the tricot were gently then aspirated from the macula. Brilliant blue G dye was injected, and the thick membrane was gently peeled with intraocular forceps until the margins of the lamellar hole for an inverse peel. Re-injection of the dye was done, and ILM peeling was done. Case was then closed after a complete air fluid exchange. 1 month post-operatively, his vision marginally improved to 6 by 48 N24, with the inner margins of the lamellar hole well approximated and decreased height of the schisis. But there was a presence of a paramacular hole. Thank you for your patient listening.
Thank you, Dr. Virangi, for this such a nice presentation showing to us. With Dr. Virangi, are you there? So we will take up the questions of this case afterwards after the two cases and the masterclass by Dr. Barbara. So we'll be showing the second case also along with this. This case has been will be presented by Dr. Kshitij Kumar, who is a consultant and director of the Ikshana Eye Care Hospital in Kolkata. He has more than 15 years of experience in various surgeries, and he has shown a very interesting way of operating lamellar associated epiretinal membrane. In this video film, modified surgical technique for lamellar macular with lamellar hole associated epiretinal proliferation has been described. Lamellar macular holes were first described by gas arising from an abortive process of full thickness macular hole formation. These generative LMH are associated with an atypical ERM or LHEP, which are thicker, non-tractional, and arises from inner retinal layers. And such holes have poorer visual acuity, large hole diameter, round edge cavitation, and higher incidences of ellipsoid zone disruption. Following injection of BBG dye, LHEP gets marked out distinctly from surrounding stain ILM. In some cases, they can be identified as thick yellowish tissue around the LMH defect. Raising the flap of LHEP is challenging as it's thick, gummy, sticky, and tightly adherent to underlying retina. Therefore, the patience is the key here, with utmost care taken to make a wall of LHEP flaps around lamellar macular hole. BBG staining of underlying ILM around LMH is redone, and ILM flaps are made around LHEP flaps to cover them. The basic principle of this technique is to embed the Muller cell-rich LHEP tissue back into the lamellar macular hole defect, as the origin of LHEP is from the inner retina, and thus the Muller cells produce growth and trophic factors to close the defect. You can see in this case a good recovery of focal contour and functional outcome happened. Using the that was a very interesting cases by our two surgeons, Dr. Virangi Doshi and Dr. Kshitij Kumar. Thanks for that. And we will take the questions after our one more masterclass by Madam, which will be on the lamellar macular hole, how to go and interpret and treatment. Over to you, ma'am. We are waiting this presentation also.
Thank you. Okay. All right. I hope you can see well, right?
Yes, ma'am. Yes.
Okay, let's see what we need to know on lamellar macular hole. This is an overview of the main vitreoretinal interface disorder. They all have in common a disruption of the fovea. And let's go through briefly through the history, because history always teaches something. The first one that described this entity was Donald Gast in 1975. He defined a lamellar hole as derived from an unroofed cystoid macular edema. So he had the intuition of tissue loss, and he defined the pseudo hole as a contraction of an epiretinal membrane simulating a full thickness macular hole. So he had the intuition of contraction in the case of the pseudo hole. And then it's interesting that for 30 years, nobody said anything more until we had the high resolution OCT, and Witkin described two different entities, two different epiretinal membranes associated to a lamellar macular hole. And a few years later, my group and I defined a correlation between the histology of the two epiretinal membranes with the OCT aspect of these membranes associated to different lamellar macular hole. At the time, believe me, nobody was speaking about this, and there was no knowledge at all about the different entities. I will explain better in detail what we discovered. Then we had this international group redefining the definition of the vitreomacular disorder. And in 16, Govetto differentiated the generative and tractional lamellar macular hole as a description, let's say, based on OCT. And then in 2019, the consensus was published to produce a new nomenclature, a new classification, and this is the classification we use nowadays. So except Donald Gast that used the slit lamp, we used the OCT in the other groups. And in my work, I have used a surgical observation, OCT plus histology. So the consensus basically define these three main entities: the pseudo-hole, the tractional lamellar macular hole, and the degenerative lamellar macular hole. The first one, the pseudo-hole, is basically an epiretinal membrane, no more than that. It is a break into a regular epiretinal membrane. There is no tissue loss. So tonight we will focus on these two entities to describe the differences and the different management that we should dedicate to them. So one of the main differences to differentiate tractional and degenerative lamellar macular hole is the type of epiretinal proliferation. Tractional on one hand and dense on the other hand, as I described in my publication in 2011. So I want to show you how everything started. In 2009, I was doing an epiretinal membrane peeling in a lamellar macular hole. And please remember, at the time, we had no idea of what we were doing. I was just observing that in these cases, I was peeling this fluffy, this fluffy yellow tissue that really did not resemble any traditional epiretinal membrane. I was very afraid because I thought at a certain point that I was peeling the macula itself. It was very yellow, very fluffy, inconsistent, non-elastic, and it was difficult to find the plane of separation. At the time, we were not using any dye, and so it was even more difficult. But after peeling that, I found that the internal limiting membrane was underneath, and so I had the proof that I was not peeling the retina. So I started this paper. This was the publication where I compared 19 specimens, and these were the characteristics of the specimen, correlating what I saw with the OCT and what we found with histology and immunohistochemistry. Basically, the conclusions were that with the tractional epiretinal membrane, in the histology, we had traces of ILM, vitreous, and some cells. And in the dense membrane, we had no ILM, masses of collagen, native vitreous collagen, fibrous long spacing. I will tell you what it means, and very few cells. So the main difference was in the tractional epiretinal membrane, a few collagen and lots of cells. In the dense one, lots of collagens and no cells. The vitreous collagen, the fibrous long spacing collagen, is a type of collagen that indicates remodeling. And immunohistochemistry showed that in the tractional membrane, the main cells were glia, but also myofibroblasts and hyalocytes, and alpha smooth cells muscle. In the dense membrane, the few cells were only hyalocytes and glia. Both membranes could be peeled, but unfortunately, we found out that if you peel the dense membrane, you can induce a full thickness macular hole because we used to peel completely as we used to do with any epiretinal membrane. So even nowadays, we are still discussing about the pathogenesis, how these two entities forms. And the treatment, should we treat or not to treat? And if we treat, how and what to do? So with the tractional type, we have tissue displacement due to anomalous PVD and epiretinal membrane formation. But in the degenerative type, we don't have displacement, we have tissue loss. And why tissue loss? Anyway, let's start with the tractional lamellar macular hole. It seems that the schisis type is due to the shape of the Mueller cell that has a Z shape. And so when there is an epiretinal membrane, the Z shape creates the spaces of the schisis. And if we have tissue displacement, basically induced by the tangential traction of the epiretinal membrane, the treatment will be epiretinal membrane peeling. This is easy and intuitive. But after the peeling, the question was, should we do an ILM peeling or an ILM flap to avoid a full thickness macular hole? Well, this is an example. We had this tractional lamellar macular hole. This was a time when we had fear. I had fear to induce a full thickness macular hole in lamellar holes, to induce a full thickness macular hole. So what did I do? I tried in a few cases to elevate the internal limiting membrane without peeling completely and leaving a flap on top of the tractional lamellar macular hole and see what happens basically. So this is the peeling. I will speed up. And as you see, I leave a flap under air. But what happened? I didn't have a good result because I still could see the ILM flap and the contour was not regular. The patient still had metamorphopsia. But we thought, let's wait. Maybe there will be some remodeling. The answer is no remodeling. The ILM flap remains exactly there as you leave it. And you see, I left it there for more than 1 year, but the wrinkle remained. She had metamorphopsia and complaining. So in the end, you see on the right side, I removed the ILM flap and I had a good remodeling of the fovea with restoration in vision. You see in summary here from pre-op to the ILM flap with wrinkles to the ILM flap removal with good restoration in vision. So my message is, if you have a tractional lamellar macular hole with an epiretinal membrane on top, just remove the epiretinal membrane and don't leave any flap. This is it. But if we go to degenerative lamellar macular hole, this is a completely different disease. We don't know why we have the tissue loss. I will show you what we know about the natural evolution, and there is probably an association with the loss in the nerve fibers too, and I will show you what I have learned about treatment. There are only hypotheses on the formation, hypotheses of neurovascular retinal unit damage. But believe me, you find different proposals in the literature and none of it is still validated. It makes you just think that this is not only about traction, but probably also about a degenerative problem that could be neurological or vascular. We still don't know. I have my own hypothesis and I will propose. So what about natural history? So what happens to this degenerative lamellar macular hole if you do nothing? It is very variable. It is described that they can spontaneously close, and that's also why most of the colleagues suggested to observe them and do nothing. But they can also develop a full thickness macular hole, like in these examples. So I observed that even the opposite can happen. You can have a full thickness macular hole first that can spontaneously close and then can switch to a degenerative lamellar macular hole. Let's see this example. This patient was I operated this patient in 2017 for rhegmatogenous retinal detachment. The surgery was okay. The patient gained vision and a very good retina. But 2 years later, he developed a full thickness macular hole. 2 years later, he refused the surgery, so I did not operate him. He actually, you can see a spontaneous closure of the full thickness macular hole. And look, the fovea looks very, very good, good profile. And then 2 years later more, he developed a degenerative lamellar macular hole, which was very impressive to me. No vitreous, so this doesn't come from vitreous detachment. It just opens up. And he refused any surgery. I'm still following this patient, and he had just a deepening of the lamellar macular hole. This is another case. This patient with high myopia developed a very small but full thickness macular hole that spontaneously closed a few months later. And 2 years later, he developed a degenerative lamellar macular hole that deepened a lot. And actually, at the time, I actually operated him. But this is to show you the switching from full thickness to degenerative lamellar macular hole. What is this relationship between degenerative lamellar macular hole and loss of nerve fibers? Well, I'm just collecting information. I have observed that some of these patients have a very bad visual field. So I am trying to correlate the appearance of the degenerative lamellar macular hole and loss of fibers. I don't have enough data, but this is something that I propose also to you to look at, because this is very interesting. So what about treatment? Does it make sense to treat them? As I said, in my first publication, I was reporting the fear of inducing a full thickness macular hole if you peel the membranes here. But that is why the literature is so controversial. You find the literature pros and cons surgery, but this is due to the classic peeling. If you go inside this eye, you remove the epiretinal proliferation and remove the ILM, you will induce a full thickness macular hole, most likely. But as we have seen in the video of one of our colleagues, if you don't completely peel but embed the tissue back into the hole, then you will have a very successful surgery. So this is the surgery in one of my patients. Actually, I can skip on the cataract side. Let me go to the surgery. Yes, so first staining. Again, it's very difficult to find the plane. You don't see the epiretinal membrane. You only see yellow fluffy tissue. But slowly, and it's very important to be very delicate and not to pinch too much the retina looking for the plane, because you might induce an extrafoveal hole, as actually it happened in the first video of our colleague tonight. So anyway, you peel 360, the epiretinal proliferation. By the way, I suggest to call it ERP and not LHEP, because this is not only linked to lamellar macular hole, but this fluffy yellow tissue can be observed also in full thickness macular hole, in uveitis, in other entities. So don't call it LHEP, call it ERP, epiretinal proliferation. This is the second peeling, the second staining to peel the internal limiting membrane. So I used to trim some of this yellow fluffy tissue, as you can see with the intraoperative OCT. And then I switched to peeling the ILM and creating a big flap. As you can see, I have a small flap of epiretinal proliferation. And then this is the same technique that our colleague just shown us. So elevation of epiretinal proliferation, elevation of the ILM, a big flap to cover both membranes. This is in summary the technique. And then fluid exchange, you can use some gas, but I think a short acting is more than enough. So this is the summary of the surgery. And yes, I confirm that you can have a very good result if you keep the membrane inside the hole. You see on the left, the pre-op, and on the right, the post-op. And vision actually gain and improves in an average of 2 lines. This was published. Also, microperimetry can improve. And it's better to intervene soon because if you don't have a damage in the photoreceptors, the final visual acuity will be better. Instead, when I showed spontaneous improvement, but with the spontaneous improvement, the visual acuity was not restored significantly. So it seems that the result of vitrectomy with the embedding technique leads to better visual results. So we should operate these holes because they lead to decreased vision and metamorphopsia, and they might lead to full thickness macular hole. Even when they spontaneously close, the type of closure does not favor vision. Surgery with epiretinal membrane embedding and ILM flap leads to improved vision. And my new hypothesis is that the degenerative type can occur after vitrectomy without PVD. And as you have seen, it may occur after a full thickness macular hole. There might be an association to nerve fiber deficit. And my hypothesis is that they could be a result of an activation of the Mueller cell to react to a wound, for example, the full thickness macular hole. And so I think they could be a wound healing response that leads to migration of Mueller cells and splitting at the edges of the fovea. That's why placing back the fluffy tissue with the ILM can lead to a restoration of the foveal contour. But this is just an hypothesis.
That's
Thank
a wonderful presentation by you, ma'am. And from now on, I think we will start talking epiretinal proliferation instead of LHEP, what you are mentioning of it.
Well, it's commonly known as LHEP, but it's not linked only to lamellar macular holes. So that's why we should use epiretinal proliferation. That's it.
So rightly said, ma'am. In some of the studies with macular hole, also you may get these epiretinal proliferation, where they are called MHEP, macular hole associated epiretinal proliferation. So yeah, the right terminology would be ERP.
So coming to Dr. Shritik's case, first about a discussion part of it, what do you think your approach, the way he did, where he embedded the epiretinal proliferation inside the lamellar hole. What are your indications to go for a surgery, and do you do the same technique or any other point from your side on that case, ma'am? The second case which Dr. Shitish did.
Yeah, actually, I totally agree. As you have seen with Dr. Kumar, we have used the same technique. And nowadays, if I see a patient with decreased vision, metamorphopsia can or cannot be present, I do propose the surgery. I propose the surgery. Of course, I decide with the patient, but I feel safe that by using this technique, we can improve vision and the history of this patient.
Any chances of gliotic formation have you seen after epiretinal proliferation if we embed and we leave that? Gliosis can occur over the fovea. Is it possibilities there? No?
No. No, I think now I have a 5 years follow-up, not just mine. I'm collecting actually cases in a multi-center trial, so I've seen quite a few, and there's no gliosis formation in time.
When is the average time in the OCT we can see that epiretinal proliferation is disappearing from that area? Have you seen noted?
You mean after surgery?
After surgery?
Well, this is a very difficult question. I haven't noticed. I don't know if I would be able to judge just by the OCT if it is remodeling or disappearing. I will look into that. This is a very interesting point. I haven't observed.
Coming to the first case by Dr. Virangi Doshi, what the surgery, a very wonderful surgery, what they have shown. The patient also had a retinitis pigmentosa in that patient. So, do you feel any retinitis pigmentosa or any other retinal disorders which can lead to thinning of the retina can be one of the reasons to have that paramacular hole? Or do you change your steps in those cases?
No, actually, my thinking is that the paramacular hole could be due to a pinch. It's iatrogenic because it can happen also in patients without retinitis pigmentosa. And as you have seen, it's not the fault of Dr. Virangi, because this tissue is very difficult to see. And it's very difficult to find the plane of dissection. It's not like tractional classic epiretinal membranes. You need to look for it sometimes, so the pinching is inevitable. Sometimes I also use a scraper just to be able to find it better. And there are some staining that helps in staining the epiretinal proliferation a little better. So I think we should use them too. So that's what I think.
So that was a
I think
wonderful
it
discussion.
will be insignificant on vision, so it will remain like that, and no need for treatment. So don't worry, you'll be good.
Yeah, that was a wonderful discussion. Dr. Virangi, anything, you have a latest follow-up on the patient by chance? You're muted, I think, Virangi. We are not able to hear you.
Am I audible?
Yeah, now
I
you're
have
audible.
actually joined from another device also. So that was the latest follow-up. That was about 15 days back. And that was the latest OCT also. Also, I had a question from for Dr. Barbara. It's been a delight learning from you. Also, my question was that what would be the ideal time to operate according to you in such degenerative lamellar hole cases?
So I think when the patient, on the OCT side, anatomical side, I suggest to operate if the depth of the lamellar hole is in the outer layer, definitely operate. Better not to wait to reach that level, because the postoperative vision is correlated to the depth of the lamellar macular hole. So if the patient is willing to undergo surgery, I think that as soon as you see that the lamellar hole is reaching the outer layer, suggest the surgery. Because with this technique, you can feel reassured that you will not induce a full thickness macular hole. You will have a much better profile. So don't wait too much.
Thank you.
Dr. Sharad, may I add
Thank
one
you.
point?
Yeah.
Yeah, so just a surgical caveat. So, as ma'am showed in her study, how first approach should be to, whenever you come across with a lamellar defect, to classify into tractional versus a degenerative hole. So, what we see in tractional ERMs, that once you have removed the ERM and again you have gone in and re-stained it, you would see that these fractional ERMs sometimes take away the underlying ILM also. So both the peel happens at the same time. Vis-a-vis in the degenerative lamellar holes, when you remove these epiretinal proliferation and when you go and restain the ILM, invariably the ILM would be intact.
Sure.
So that's one
That's
of the
a
observations.
very interesting
This is very important, and you're right. And if you recall, when I reported my finding from 2010, 2011, the histology, actually, one of the main finding was that in the tractional one, there were always remnants of ILM. In the dense one, there was no ILM. So when you remove that, it's totally on top. and it doesn't stick to it. That's why I really think it's a completely different thing. In my point of view, those are Mueller cells which are activated by a wound, and they spread all over trying to close the wound, but instead they open up a degenerative lamellar macular hole. I cannot prove it. I would love to be able, with your help, to collect samples and prove it. At the same time, I suggest you to run a visual field in these patients, because I would really like to better understand the visual field, and also the optic fiber thickness, to study a correlation with those data as well.
So that was a wonderful discussion on lamellar macular hole part of it. So now we move around to the other interesting vitreoretinal interface disorders. And the next case will be by Dr. Ahmed. So next case will be by Dr. Ahmed Hassan, who is a lecturer and retina consultant at Research Institute of Ophthalmology, Cairo, Egypt. Thank you for sending the case, Dr. Ahmed.
Thank you.
Showing his case. This video depicting remove. Just a second, sorry.
ILM peeling in large macular hole. 59 years old male patient presented with diminution in vision in his right eye. His vision was 360 and he was diagnosed with large macular hole. Masterclass vitrectomy. Full vitrectomy was done. Clear hyaloid detachment. PPG dye was used to stain the ILM. Followed by ILM gear. Inverted envelope technique was done. Fluid exchange was done. Percent SF6 was injected. Weeks post-operative OCT. Vision improved to 6.
So that's a very wonderful surgery done by Dr. Ahmed, which shows the classical inverted peel surgical technique which he has done. So recently I went through some study on done by Dr. Barbara, that is called a small study, where they showed us when to do ILM peel and what are the effects of the ILM peel. Madam, can you put on some more points on that?
Well, yeah, the point is that Well, first of all, it's very interesting that even in 2025, we are still learning on that. We don't have all the answers, but we have understood that the ILM flap has revolutionized the results of the surgery, where can reach anatomical success more easily. However, we are also learning about the side effect of an ILM flap. For example, in this case, we in the post-op, we see a restoration of the contour because there's no hole, but in the hole we have the ILM flap. And therefore, the improvement in vision is blocked, totally blocked by the ILM. So we only have an anatomical improvement, but not so much visual improvement. So we should be able to keep the flap on top without stuffing the flap inside the hole to really promote the real closure of the retina edges itself. And when the hole is smaller, we should avoid the ILM flap at all, because we are inducing all the side effect of ILM feeling, like the touches in the nerve fibers that appears in the thinning in the donfle, and that can appear as a small scotoma in microperimetry. So when the hole is very, very small, less than 250 microns, it is advisable. And this study, which was a very large multi-center study that collected more than 600 cases, it was demonstrated that for a very small hole, we can just detach the vitreous in a very, very small hole, like we are releasing vitreofoveal traction. And in a smaller than 400, we should just do the peeling of ILM and reserve the ILM flap for holes wider than 400 microns. Telling the truth, I want to tell you my opinion on that. I think that when the ILM is gone, is gone. And doing a free flap afterwards, because we were unsuccessful, is much more difficult. So my suggestion would be, don't remove completely, even after even in large, holes around 400 microns. Just keep for the next surgery, if necessary, some ILM. So elevate the ILM, but leave it there. Even not on top, it doesn't really matter, but keep it there, because if you need it for a reoperation, you will be able to use it. The point is, try always to use it on top. In a case like the one that our colleague just shown, the hole was very large. It was more than 600 microns. So it's inevitable sometimes to have ILM inside the hole, even if you don't push it inside the hole. So what I have observed, I would like you to try, when the hole closes, like your patient, but you don't have a very significant improvement in vision, a few months later, you can remove the flap, and the retina will close completely, and you will have an improvement in vision. Because at that time, you already stimulated the wound healing response, and you might have an improvement in vision by removing the flap.
Thank you, ma'am. So by the scarcity of the time, I think other questions we can take it in the chat part of it. And we'll thank Dr. Ahmed for presenting this wonderful case.
Thank you, sir.
Yeah, next I'll be presenting the next case. So the next case is by Dr. Indranil. So just so the next case is by Dr. Indranil Saha, who is the Associate Professor and Vitreoretinal Surgeon in RIO Sitapur Hospital. Thanks for sending this case. I was just showing this case. This is a video depicting removal of a taut epiretinal membrane over the macula. The patient had undergone a primary surgery for near closed funnel retinal detachment a year ago. A cautious edge is created from the nasal side of the epiretinal membrane using an intraocular forceps. Silicone oil removal has been done, and now this tight membrane is being peeled. The inferior edge is being peeled towards the fovea. The superior edge is also being managed similarly. At a low suction, the cutter helps debulk the membrane. Further mobilization of the epiretinal membrane and debulked again with the cutter. And now, the free edge of this residual epiretinal membrane is grasped and carefully removed. Hemostasis was achieved and case was closed with 14% C3 epi gas tamponade. Thank you. That was a wonderful case by Dr. Indranil. Indranil, are you there?
Yes, thank you, Dr. Sharad, and thank you, organizers, for this wonderful opportunity. And ma'am, it's actually a humbling and an honor to for your presence to witness our surgeries. So this particular patient, ma'am, actually pre-op, as in with the oil and the ERM, had a BCVA of 3 by 60. That is a logmar of 1.3, and post-op surgery 2.5 months after the gas went off, the BCVA was 6 by 36, 0.78 logmar.
All right.
That is a very wonderful surgery done by Dr. Indranil. Ma'am,
can I comment on this?
yes, ma'am. Yes, we are waiting for your comments.
Yes,
So this was a very difficult case and a very difficult surgery. The only thing that I would like to propose as an alternative is, since this is not a common epiretinal membrane, it is basically like a flat PVR. It is a gliosis with focal strands on top. I would have tried to use a scissor to delaminate and find some planes and use more the scissor to cut and separate, eliminating the traction and creating small flaps. In that way, when you pull just the single flap, you create just the focal traction and you don't have to drag the whole membrane from one side to the other. So you might be able to reduce the trauma on the epiretinal, so on the retinal tissue and the hemorrhages, because that's the only way that I would have done differently. I would have certainly do the peeling and I would just use more the scissor and than the forceps.
thank you.
When is the optimal timing for you to intervene in these cases, ma'am? So post-vitrectomized with silicone oil filled eye. So usually if you see this epiretinal membrane by 1 month or 2 months, are you going to intervene early or you'll wait till the membranes to get matured or anything like that?
There are different factors, I think, to consider in cases like this, because it's not only what we think is right. We have to listen to the patient as well, because these are patients that have been operated multiple times, and it's not so easy to go back every time we would like. So I think it's better to at least wait until we are able to define and really see the membranes. So we know that we will be more successful when we go inside. But on the other hand, if the macula becomes very, very wrinkled, sometimes it's difficult to obtain a good postoperative restoration. So anyway, I think that was a good timing because you could clearly see the epiretinal proliferation, so you were able to remove it completely. Otherwise, we risk to leave some. And I also think it is better for some patients to wait between surgeries. Otherwise, we finish one surgery with the silicone oil, they still have a red eye, they just, leave the previous surgery, they are not ready to go back to the OR again. So I think also the total inflammation of the eye should calm down before going back to surgery.
So thanks, ma'am. So from this, we'll go to the one more interesting case by my friend Dr. Apurva Ayachit, who is a consultant who is a consultant via surgeon in MM Joshi Eye Hospital, Hubli. So she'll be showing her interesting case. Yeah. So what?
Measures for extreme epiretinal membranes. A 49-year-old man presented with sudden diminished vision in the right eye for 2 days. There was a large subhyaloid hemorrhage at the macula which was clotted, along with venous tortuosity and white-centered hemorrhages. His blood pressure was normal. There was a reactive thrombocytosis picture with raised ESR and CRP. An intravitreal anti-VEGF was given. At 1 month, a retinal artery macroaneurysm was seen at the superior arcade with overlying fibrosis and a premacular thin film of fluid and blood, but there was no epimacular membrane. Later, 2 months, there was a breakthrough hemorrhage with a thick ERM which was grade 4. This is the surgical video. This is the vitreous hemorrhage being cleared using 25 gauge pars plana vitrectomy. After clearing of the vitreous hemorrhage, we saw that there were multiple layers of vitreous denoting vitreoschisis with adhesion at the epicenter of the ram. We can see conformal delamination, segmentation on top of the ram. Here, laser was being done, which in retrospect was maybe not necessary. This thick membrane is being removed with a forceps. It's a very broad attachment along the superior arcade. Slowly it was peeled using the disc as a fulcrum. Now we can see that there is a focal retinal off near the superior arcade at the ERM at the ramp. And now the hyaloid is being separated from the posterior pole. Now a pick was used to release the overlying traction on top of the ram. When this was going on, we saw that the story was much more. There were secondary membranes all over the superior arcade, which were extending to the overlying vitreous traction. Peeling was attempted, but then bimanual segmentation had to be done to separate the traction. Now the retina is slightly off, but a careful peeling of the ERM is being done, which was possible to a large extent. But the macula is very puckered, as you can see. There is a chronic macular fold. A BBG-assisted island peeling was done. You can see that there is severe pucker of the fovea. Now, the unconventional step of subretinal balanced solution injection was done. Here you can see the intraOCT demonstrating the subretinal injection of the fluid, and we can see that the foveal contour returns on table itself. A fluid air exchange was done, laser done around the hole, and gas was injected. This is the pre and post-op comparison. At 1 month follow-up itself, the IFL has verified and it's already normalizing. This is a very flat macula without the fold at 3 months. Thank you.
So that was a very interesting and a rare case which has been presented by Dr. Apurva. Your thoughts on this, ma'am?
So I want to congratulate with my colleague. This was a very complex surgery, and you made some interesting choices. In previous cases that I have encountered of macroaneurysm with vitreous hemorrhage, I've performed vitrectomy, and in a few of them, I only had to perform vitrectomy and treat the anomalous vessels. What I usually do, I do just the laser around the macroaneurysm, and that's it. The epiretinal formation is not there all the time, so you had to fight with that too. I think that if I had done your surgery, I'm not sure I would have done. I would be right or wrong, but I can tell you I'm always scared when I see a lot of subretinal blood or a case at risk of subretinal bleeding, because you can find yourself in a mess, in a total mess. So I can tell you, I would have definitely considered a stepwise surgery. I think I would have stopped myself at the pinning of the main membrane involving the macula, and I would have not pulled, as soon as I would have seen the retina coming off, the detachment, I would have stopped. I would have covered the break on top of the subretinal hemorrhage with something, with even with the epiretinal membrane itself, without peeling completely, just to have a cover over the break, and sealed with the laser and fluid exchange and gas face down, things like that, thinking that the hemorrhage would have gone away. I would have observed the flow of the wrinkles, and if they were significant, I would have gone back to a second surgery. But I cannot tell that my choice would have been better, because you had a great result, so I should consider. It's just a warning. In general, when I see, since I had bad experiences, when I see elevation of the retina with subretinal bleeding, I try to stop if I can.
Yeah.
Thank you so much for that insight, ma'am. Actually, looking back at the video, I had multiple mini heart attacks about what I was doing when I saw the surgery again when I was seeing my own video. I also wonder why I made those choices. But one of the things that I do whenever I have a membrane and I have a break, unfortunately, I make sure I remove that membrane completely around the break, because I don't want reproliferation, and I definitely don't want a macular proliferation and lifting off like a TRD involving the macula. The second thing was that there was a definite fibrous proliferation from atop the ram to the macula, and we can see that the macula actually had a fold because of a severe pucker. So I knew that I had to take care of that entire proliferation in order to free the macula. I think the subretinal injection was overkill. I think that was too much. But somehow I've been using that, especially when I see a macular fold, a linear one, and I know from some experience, maybe 4 or 5 cases, that I see that fold and I inject subretinal BSS, and I see like a magical restoration of the fovea very quickly compared to when I don't inject subretinal BSS.
I understand. The point is that you put yourself at high risk of inducing a full thickness macular hole, and that becomes a second nightmare. So sometimes, and I tell you from my mistakes, I went to fold, to hold, and so to lack of restoration of vision. Sometimes it is wiser to stop and explain your patient that very likely he will need a second surgery just in case the vision does not come back. The second point, another mistake that I have done is to try and take care of the subretinal hemorrhage by aspirating the hemorrhage through the hole. That is a very big mistake because most of the time, even in a few minutes, it becomes a clot. You aspirate and a small hole becomes a big break. So don't do that. I totally agree with you when you say, I don't want to leave epiretinal traction over a break. It's like a tractional retinal detachment. But one option, instead of removing everything, is to elevate the epiretinal traction and keep it on top of the hole just as a plug, because that, especially if you still have blood underneath and you cannot remove it, you plug it, and so the hole is not exposed, and it helps solving the case basically. But anyway, I totally understand your choices.
One more interesting point what she showed, and a very interesting biomarker what she showed, ectopic inner foveal layer. In the recent classification, they have shown that biomarker which has been used in the epiretinal classification. How much commonly used nowadays, ma'am, about that biomarker? Ectopic inner layer.
Ectopic
Inner foveal layer. Yeah.
Ectopic inner foveal layer, you mean in the staging of the epiretinal
Staging of the epiretinal membrane, yes, ma'am.
Okay, well, I use it now as indication of surgery. I used to indicate surgery years ago only when the patient used to have a severe drop in vision, and probably I used to operate in stage 3 or 4. But today, actually, I anticipate the surgery, and I learned that because one day I operated a stage 1 epiretinal membrane. And you know why? Because the patient was a colleague. Actually, he was a Vitreo-retinal surgeon who came to me and said, I know everything about epiretinal membrane, but I cannot do my job. I have metamorphopsia and I cannot operate through the microscope. So peel this membrane. So I peeled the membrane, and he had a perfect restoration in vision. He went to 20/20, no metamorphopsia. And so he taught me actually by doing that we should not wait for ectopic layers, because the final restoration in vision is much better. It takes more courage, maybe more craziness, but the final result is definitely more rewarding.
Both the doctor and the patient are courage in this case. Thanks, Dr. Apurva. So now we will go to the last two cases on diabetic retinopathy membranes. The first case will be presented by Dr. Shishir. I'll just share the presentation. So we are just overshooting by some time, but we'll finish it in some time.
This video is about extreme measures for BMT release in PDR. A 68-year-old female presented with complaints of decreased vision in the right eye. Her vision in the right eye was 2400. She was diagnosed with right eye lasered proliferative diabetic retinopathy with vitreomacular traction and lamellar hole. She underwent right eye 3 port pars plana vitrectomy. A core vitrectomy was performed, following which the posterior hyaloid was identified and truncated with the cutter. After completing the vitrectomy, BBG dye was used to stain the internal limiting membrane, following which an ILM peel was performed. A tuft of tissue was left behind over the lamellar hole. Additional Edna laser was performed. This was followed by fluid air exchange and triamcinolone injection. 20% SF6 gas was injected at the end of surgery. It was interesting to note that there was intraretinal deposit of triamcinolone at the macula 2 weeks post-operatively. 1 month post-operatively, her vision improved to 20/80 with a closed macular hole and regaining of the foveal contour.
So thanks, Dr. Shishir. I forgot to introduce Dr. Shishir. Dr. Shishir Varghese is a consultant vitreoretinal surgeon in Amita Eye Care, Tiruvalla, Kerala. Recently, he's in a core of our group also, and he is presenting in many various conferences. And recently, he has got a honor award of ASRS also. Congrats, Dr. Shishir. We will take up the questions along with the second case also, which has been sent by Dr. Aarti Mohan Kumar, who is a consultant VR surgeon in Rajan Eye Care, Chennai.
PMT
Epiretinal membrane post-diabetic vitrectomy. A 65-year-old male with fractional retinal detachment due to PDR underwent vitrectomy with silicone oil injections. Post-surgery, he developed a thick ERM with skytic macular edema and had a visual acuity of counting fingers at 3 meters. Silicone oil removal with ERM peeling and DEX implant was done. After silicone oil removal, BBG staining was done and ILM peeling was initiated in the superior macula. As the peeling was done, the membrane was found to be densely adherent at the inferior arcade to a laser CRA temporally and close to the disc nasally. The membrane was gently dissected but was found to be quite adherent. A horizontal scissors was used to release the attachment close to the laser CRA. Then again, ILM peeling forceps was used to loosen the membrane. The ILM was peeled from another edge in an attempt to slacken the membrane and find a plane. The vitrectomy cutter was then used to trim the peeled redundant membrane. After sustained efforts, the membrane detached from the retinal surface with attachment to the laser CRA, which was trimmed with the cutter. Fluid air exchange was done. Laser was done to an area of suspected retinal break close to the CRA. DEX implant was injected and the case was closed with air. At 2 months post-op, patient's visual acuity improved to 624 with resolved CME.
So that was the two wonderful cases which have been presented by Dr. Shishir and Dr. Aarti. One is the pre-surgery developing a diabetic ARM, and the second is the post-vitrectomy developing a secondary ARM in a diabetes. What is your thoughts, ma'am, on these two cases?
Both very difficult and very well done. In the first case, it was not clear to me how you could have subretinal or intra-hole triamcinolone. How could it go through?
Yeah, it was shocking for me also, ma'am, because When she came 2 weeks post-op, once the gas absorbed, the vision did not improve. It was the same as the pre-op vision. But then I just waited for a couple more weeks, and then when she came back after a month, you could see that the deposit is completely gone, and she's got back her improvement in the vision. So I think it's dropped down into the hole, and once the hole is closed, it's got deposited.
Yeah, probably you ended up with a very small full thickness macular hole with some triamcinolone stuffed inside, but then it acted as a wound healing response, and then it closed completely. That was actually very good, because I had a patient in the past where I had some triamcinolone going. It was a retinal detachment case, and I stained, and some triamcinolone went under the retina, and it stayed there for until the gas went away. But unfortunately, I had a toxic reaction in that case with the foveal atrophy. So fortunately, through the hole, it could be mobilized easily and did not remain under the fovea. So it was just an alert not to leave triamcinolone under the fovea for too long. For the second case, congratulations as well for the difficult surgery. I would like to ask whether you would consider, with such a thick edema, to inject only Ozurdex first, even in silicone, and then wait for the edema maybe to move away, and then go to surgery to remove the membrane. Because sometimes when we remove those thick membrane with the very significant edema, we risk to unroof the CME and create a lamellar macular hole.
This patient had actually received previous IVTM, intravitreal triamcinolone acetonide with oil in situ, but it didn't resolve. That's why we had planned for the surgery.
I see. Okay. So the Ozurdex was injected during your peeling surgery?
Yes, ma'am. During the surgery, we injected Ozurdex. This was because of affordability and insurance issues. So initially, we went with triamcinolone to look for the response. And then with the surgery, we combined it with a Dex implant.
All right. All right. I have no
peeling of
other
the
comment. It was a wonderful surgery.
I think peeling of
Thank
the
you.
membrane is important there. I think before peeling, any intravitreal may not work. So I thank everyone. So we had a wonderful lengthy 2 hours discussion today with a special wonderful masterclass by Dr. Barbara on two things, on macular traction maculopathy and also on the lamellar macular hole. We have learned many interesting points, especially the classification. I think we start classifying according to the MTM classifying what she has shown, and we have many of us have already incorporated in our practice, and we are waiting for the clinical trials because of the cost issue to get a macular buckle, and we want to do an hands-on than that. And similarly on the lamellar macular hole, we understood today to use the word epiretinal proliferation better than using the word of LHEP. And surgically, don't try to peel the membrane or the lamellar macular hole. You may convert it into a macular hole. So do step-by-step, two-step procedure. And one more nice point has been given where if it is a lamellar macular hole or a tractional macular hole, when you are peeling, most of the times ILM can come together in the tractional macular hole compared to the lamellar macular hole, where some bits of ILM can stay back in that place. Along with that, we have some interesting other cases, wonderful cases have been shown by our 8 colleagues. Very, very interesting and wonderful cases. So I thank Dr. Barbara for taking out our time of 2 hours and teaching us so many interesting points and all. We are very grateful to you, ma'am. And also we thank everyone who have presented their cases, sitting here still late night till 11 o'clock in India here, and also all the presenters. Thank you.
Thank you.
Dr.
I have
Avnish?
seen a very beautiful surgery, so I'm the one who learned, and thank all of you. I would like, this to be just the start of a new connections. My email is parolini.barbara@gmail.com, and I would like, to stay connected with you and be available to tell you what I've learned and to learn what you have to teach me. Thank you.
Thank you, ma'am. I think, as
Thank you
you
so
said
much.
it, ma'am, you are one of the best mentors we could actually approach. And over the last, I think, 6 weeks, the way we have been trying to get this presentation, the webinar, into the reality was very, very encouraging. So I would really thank you from the bottom of our heart, and I think the team has done a fantastic job here. I would really want to thank a special shout out to Dr. Sharath. I think he has moderated the session very well. I would really want to thank the presenters here because we had asked them for presentations and then we went ahead again to them to give a voiceover for their videos and they could do it. So it's very thank you so much so that we can actually club this session in the way we have it now. I would want to thank our core team of Late Night Retina and especially the UC platform where we could actually have Late Night Retina sessions. Last but not the least, Manjula ji, where with her numerotech team, where we had this flawless translation and of the presentations. So thank you so much, and thank you, ma'am, for your exceptional present. I think even after 2 hours, we all would agree that we would listen to more of this presentation. I think we could see from biopsies to intraoperative OCTs, and the in-depth analysis was just amazing. So thank you so much, and thank you everyone. Thank you.
Thank you.
Get back to you, ma'am. I think we are still not done. Maybe we'll connect real soon. And as you have said, whatever, I think you are the mentor to go to. You would be very, very, I mean, it will be a pleasure to actually work again.
Thank you. Maybe we will be able to organize a study together to better understand all the nuances of the lamellar holes. Thank you.
Thank you. Thank you.
Good night, everyone.
Good night.